to be done, and what are the measures to be taken intraprocedurally for optimal outcome. So initial evaluation, everything was already covered in the previous presentations, based on cross-section imaging, whether it is CT or MRI, and based upon if there is an ICAD, vessel wall imaging to be proceeded to rule out other causes, particularly in young patients. Initially always medical management. So if there are recurrent strokes happening in ICAD scenario, so it has to be proceeded with intervention, angioplasty plus or minus stenting. So coming to case 1, 62-year-old female patient who is a known diabetic and hypertensive on medication. She is having recurrent TAS, which the recent stroke happened 1 week back. This is the CT angio image showing critical stenosis in the region of cavernous ICA, left cavernous ICA. So this is the angiographic image showing critical stenosis in cavernous ICA region. And so initially angioplasty was done slowly, and submaximal angioplasty was done. As there is significant recoil, we proceeded for stenting, and stenting was done with balloon mounted stent, coronary stent. So post stenting, there is good flow within the stent and no distal perfusion or filling defects. This is the AP image. So post-procedure, there are no deficits, and patient is on follow-up, and power improved significantly compared to previous TAA. Coming to second case, 43-year-old male patient who is a known diabetic on medication. He had recurrent TAS even after best medical management. Last episode happened 8 days back, and currently he is having left upper and lower limb power 3/5. So even after best medical management, there are recurrent strokes in this case. So we proceeded for intervention, counseled the patient. Initially angioplasty was done. So as there is significant recoil and flow is, this is the angiographic picture showing stenosis in the region of distal ICA and M1. This is the lateral projection. And there is only flow in the central region near the basal ganglia and adjacent brain parenchyma. So even after angioplasty and tirofiban on table, there is no significant improvement in the distal vasculature. So the case was proceeded for stenting. We placed a credo stent. So soon after stenting, there is significant improvement in the circulation. You can see in the angiogram. So there was actually, during this case, there was small dissection flap was seen as a subtle filling defect. We gave on-table tirofiban, and post-procedure infusion was given for 12 hours. Post-CT, we shifted to dual antiplatelets. So coming to case 3, 45-year-old male patient. He had on-table stroke during implant removal in left radius. So patient presented with right hemiplegia and aphasia. MRI showing left MCA territory infarct with left M1 cutoff. This is the angiographic picture showing ICAD disease with occlusion of M1 on left side. So after first pass, there is no significant improvement. So slow and submaximal balloon angioplasty was done, and there is TC3 reperfusion in the entire territory. So patient power was improved, tirofiban infusion was given for 12 hours, and after that CT was done, so which showed no bleed or any, clinically patient improved, and he was on follow-up. After 3 months, the functional status is MRS2. Coming to next case, 49-year-old male patient who is a known hypertensive on medication, came to ER with right hemiparesis. Already from the onset of stroke, the duration is 12 hours, NIHS is 11. As the patient is worsening and MRI, there is significant clinical and imaging mismatch. The infarct size is relatively less, but there is clinically the patient is worsening. So we proceeded with perfusion imaging, which showed significant area of penumbra. So we counseled the patient attendants regarding plasty, as the disease is looking more like ICAD disease on imaging. So initially there is this is the initial angiogram showing ICAD disease with M1 occlusion, with tapering appearance of M1. So initially after first pass, submaximal angioplasty was done. Even after that there is no significant improvement and recoil was there. So we proceeded for stenting. Even actually soon after the stenting there is good flow within the stent, but within 5 minutes there is thrombus within the stent region. So proceeded for thrombus aspiration and tirofiban was given on table. So this is after thrombectomy and there is good flow. There is residual stenosis, hence so we gave post-procedure tirofiban infusion for 12 hours. So as there is no bleed, we shifted to dual antiplatelets. Patient improved by next day and his power also improved with residual deficits in left upper limb. He is on follow-up. His functional status after 3 months is MRS2. This is coming to next case, 62-year-old female patient. She has a history of posterior circulation stroke 1 month back. And right now her main complaint is absent right radial pulse. There is difference in BP between the both upper limbs, almost 40 mm Hg. And right upper limb claudication symptoms was there. CT angio showed critical stenosis in first part of right subclavian artery. So we suspected there is subclavian stele. This is the stenotic area in right subclavian artery. You can see clearly there is a retrograde flow in the right vertebral artery on angiogram. So post-stenting, there is good anterograde flow in the right vertebral artery. This is not a classic case of ICAD, but because of the atherosclerotic disease, this patient is having recurrent posterior circulation stroke. Hence, this was included. To conclude, in ICAD disease, always initial best medical management to be proceeded, and endovascular therapy should be done in selected patients where the considering age, recurrence after medical management, ruling out other causes of ICAD disease, particularly vasculitis with a vessel wall imaging, and based on plaque morphology on Dyna-CT or Vaso-CT. And always angioplasty to be done slow and submaximal. Tirofiban has greater role in view of preventing the thrombus or decreasing the incidence of dissection. And post-stenting BP should be maintained and it should be lowered post-stenting to prevent revascularization injury. Thank you.
Good cases and good presentation. And this one of the most difficult part to treat during acute stroke is ICAD. And then decision making should be like individual patient to patient basis. And then you can suspect ICAD from imaging itself, like I told before, like susceptibility vessel sign will not be seen in ICAD, and then calcific foci might be seen. From there itself, we can plan the treatment, and as you rightly said, balloon angioplasty first, tirofiban infusion, and then metallic placement. Thank you.
So I think fantastic cases, all variety of cases. But if you look at when you're treating a lot of ICAD patients, always it is not that flowery and a good outcome for these patients. It's a very difficult situation to treat, especially if a patient comes after bridging. That is also one more thing which I would like to add with what Dr. Shiva has mentioned. If you are sure it is an ICAD, we are a bit careful about giving IV thrombolysis in these patients, because you overall know the risk is overall going to be increased, and you want to load these patients with antiplatelets also. So that is also one thing you may consider when you are planning your patients with acute stroke. Thank you.
So I think I'll add the non-interventional part. In ICAD, these days we are also giving more of silastazole, and in some patients it does work better when they keep getting the strokes on aspirin and clopidogrel, and knowing that 40% of the people can be resistant to clopidogrel. Either you test their resistance, genetic polymorphism, or just give Ticastro for 3 months and then shift them back to aspirin and plateaus like silastazole. This is what we are following for ICAD these days.
Thank you, Dr. Teja, for the wonderful insights. And now I invite